Thank you. Welcome back. Today we are going to go over joints. Last week we went over the different bones of the body. Where the bones come together at different parts in the body are named joints. There's a variety of different types of joints, from joints that are immovable to joints that are fully movable, such as the shoulder. And believe it or not, you actually have joints in your head that start as separate bones before we're born and fuse together into our nice solid skull. Okay, so we're going to go over the different types of joints from highly movable to immovable and those in between. Classifications. Synarthroses are immovable. They're held together. I'm going to zoom in on the PowerPoint. Okay, synarthroses are immovable. They are fibrous joints. A great example is in the skull. Remember, the skull starts as a membrane. It's a fibrous, dense connective tissue membrane that ossifies or hardens over time. Eventually, all those bones fuse together into a movable joint called a synarthroses, specifically a suture. We're going to go over those specific names in the next few slides. Amphiarthroses are slightly movable. Okay, there's just a little bit of movement, not a whole bunch. They tend to be cartilaginous joints. A great example is the intervertebral discs of the spine. The intervertebral discs, if you remember, are fibrocartilaginous discs. They provide a slight amount of movement in the spine, but not a whole bunch, because they also create stability in our spine. Diarthroses are fully movable. These are called synovial joints, and if you can guess what's in them, it's called synovium. Very good. Synovial fluid or synovium helps to cushion the inside of diarthroses. It also helps to nourish the inside of those joints. Structural classification we saw on the previous screen: fibrous, cartilaginous, and synovial. Okay, fibrous joints. Sorry. Okay, fibrous joints we're going to talk about. So examples of these are going to be sutures, syndesmoses, and gomphoses. Gomphoses are going to be a peg and socket that's seen with the teeth. That's about as far as we're going to go with those. Syndesmoses are a ligamentous connection. We can see that if you zero in on that picture, either in your book or in your notes, if you could see it, it's a ligamentous connection between the distal tibia and fibula. And what that primary job for that joint is to hold it together. We don't want those two shin bones shimming around at all. We want to keep them nice and stable. Okay, so they can create a nice stable anchor for the ankle joint. Sutures are going to be the joints between the skull bones. We're going to see these specifically in lab. Those sutures start as the fontanelles, which are the soft spots. Those fontanelles, if you remember, anterior, posterior, sphenoidal, and mastoidal, help the head to have a little bit of give as a child comes through the birth canal. Once a child is born, those are going to fuse together because if you remember the consistency of brain tissue, it's very soft. So if we didn't have a nice, hard, bony skull to protect it, our brain very easily could be damaged. Those sutures are those connections between the joints, or between the skull bones. Okay? Cartilaginous joints, as I mentioned before, we have pads or discs, such as the pubic symphysis or the discs of the spine. Okay, those are called symphyses. And synchondroses, which is the epiphyseal growth plate. If you remember, I'm going to zoom in on that picture again. Okay, the upper left hand of the screen, that is a synchondroses. That is the epiphyseal growth plate. Okay, that is considered a joint until it fuses. Once we reach either 18 or 21, 18 in males, 18 in females, 21 in males, okay? And that doesn't really give us a lot of movement, okay, back and forth, but it allows the bone to lengthen, okay? You could see the costal chondro cartilages there. And those cartilages, which are between the sternum and the ribs, provide a little bit of movement. If you could think of what activity we would need a little bit of movement in the chest, it would be with breathing. Okay, over time, those are going to calcify and they aren't going to move as well, and a patient can have a little bit more difficulty as they age with breathing. Finally, you can see in the lower right-hand corner the fibrocartilaginous discs. We have a little bit of movement in those discs between the vertebra, not a whole bunch because we want to have some movement so we can actually move through space, but we want stability as well so we don't have too much movement on the spinal cord or the nerves coming out of the spine. Synovial joints, we're going to zip through this and then I'm going to bring it into the next slide, which actually shows you the picture. Synovial joints are highly movable joints such as the hips and the shoulders. They are covered by fluid, I should say filled with fluid, okay? There's an articular cartilage, a joint capsule, joint cavity, and a joint capsule, synovial fluid on the inside and reinforcing ligaments. Okay, I'm going to keep it zeroed in so we can look at those structures. And if you can't see this well, please pause the tape and open up to the picture in your book so you can read the words as I start to explain them. Looking at this picture on the left, you can see the inside of the joint is going to be filled with synovial fluid. So that space is called the joint cavity. It's filled with synovial fluid, and that synovial fluid helps to cushion the joint, provides a little bit of spring to that joint, but it also nourishes the inside of the joint, specifically what is called the articular cartilage. So if you could find articular cartilage on this picture, you could see on the ends of those long bones, we have what's called articular, which means it's touching cartilage. We need that articular cartilage to provide a little cushion on the ends of bones, or we would have the bones bumping up against each other. That articular cartilage is made of hyaline cartilage. I've joked in the past that when you eat a chicken wing bone and you get that chewy part, that's articular cartilage. Gross, but true. And what it does is it helps to cushion the ends of those bones. When we start to get wear and tear on joints, that articular cartilage actually will start to wear away, and you could get little pieces of it in the joint, and you get that popping and clicking in joints. Moving to the outside, you could see the articular capsule or the joint capsule. It's actually made up of two parts. There's a fibrous outer portion. Towards the inside is a synovial portion that's touching the synovial fluid. And that joint capsule provides a nice protection on the outside of the joint, keeps the synovial fluid in, and protects the ends of the bones as well. On the outside of that joint capsule, you'll see ligaments. Those ligaments cross the joint. There's ligaments across every joint that help to support and hold the bones together. In joints that have more movement, there's going to be smaller and fewer ligaments. In joints that have no movement or limited movement, there tends to be thicker ligaments, or joints that bear a little more weight as well. Okay. Bursa and tendon sheaths. So when we think about highly movable synovial joints, such as the shoulders and the hips, we need to keep in mind that with that increase in movement, we're going to have less stability. When you have a joint that can move in a multiple range of motions, when we're doing our activities, there's going to be an increased incident of possible injuries because we have more movement in that joint. One of the things that we have in our joints that helps to protect them are bursa and tendon sheaths. Bursa are little fluid-filled pockets that are put in areas of high wear and tear. So for example, underneath the acromion, which is the point of the shoulder that the clavicle joins up with, there's a subacromial bursa because there are tendons that pass underneath it. That bursa helps to protect the tendons from the wear and tear of the bone rubbing against it. Okay, so bursa are put in little bags of fluid that are put into areas of high wear and tear. Now, if you could imagine a tendon, and if you could imagine wrapped around it, we have a tubular structure that is also filled with fluid, very similar to that bursa. That is a tendon sheath. Same exact job. That is put into areas of high wear and tear. We have one in the biceps right here, which you can imagine. You've seen me moving because I always talk a lot with my hands, moving so much. There's a lot of movement over this tendon, Around this tendon, we have a nice tendon sheath to help to protect it against all that wear and tear. Okay. Moving those bones. Okay. Now we're going to talk about muscles. I want you to think for a minute about muscles and where they are in the body in general. Of course, there's over 600 muscles. They're everywhere in the body, from teeny tiny, almost microscopic, to humongous muscles this big, okay? In order for a muscle to move a bone, it needs to cross what structure? I want you to just think for a minute, okay? It needs to cross a joint, okay? So if I'm talking about my wrist joint, in order to move my wrist and my hand, a muscle needs to attach from my forearm, and it needs to cross the wrist joint in order to move that joint, okay? That's just an important concept. If I had the muscle just crossing from the radius to the radius and it contracted, it wouldn't do anything, okay? So muscles need to cross joints in order to make them move that joint, okay? When we're talking about a muscle, there's two ends to the muscle. Do not overthink this, okay? It's purely the definition of the two parts of the muscle, the beginning and the end. So if I'm talking about the bicep muscle, the beginning of the muscle is the origin. The end of the muscle is the insertion, okay? The origin is the beginning, the insertion is the end. The origin has some very specific characteristics. It is immovable, so it does not move, okay? So my bicep muscle, its primary job is to flex my elbow. So if you put your hand on your shoulder and you flex your elbow, I mean, there's gonna be a little wiggle there, but for the most part, that origin is not going to move, okay? The insertion is the movable part. So that's one of the first definitions, okay? The other definition, and we're going to get into this in muscle in a little bit, okay, is the origin is closer to the center of the body or the most proximal part of the extremity, okay? We're going to get into this again. The origin is closer to the center of the body, so more proximal, or it's closer to the center of the body, more medial. The insertion is going to be further away. It's either going to be more distal or lateral. Okay, it's just the definition. We're going to go over it again. Okay, it's just a little introduction. And when we talk about moving the bones, there are very specific movements that we need to talk about. Okay, so I'm going to zero you in and give you the definitions of the actual movements. There's flexion and extension. So flexion is decreasing the angle of a joint. Bending the elbow would be flexion of the elbow. Extension would be increasing the angle of the joint. Extension would be straightening the arm when we're talking about extension of the elbow, okay? Abduction and adduction. I say abduction is to move away from the body. Adduction is to bring it towards the body, okay? So abduction is to move away. Adduction is to move towards the body. Some people think of it as adding the body parts to the body, okay? By moving the arm down and in, you're adducting and adding the arms or the legs to the body, okay? Supination and pronation, okay? I do not use this for the feet. You can see they use it for the feet. I don't like it for the feet. When the foot rolls in, I call that inversion, I-N-V-E-R-S-I-O-N. When you roll the foot out, I call that eversion, E-V-E-R-S-I-O-N. So inversion and eversion. I use supination and pronation. You could use it for the whole positioning of the body. Okay, so if you're lying face up, you are supine. If you're lying face down, you are prone, P-R-O-N-E. The hand, when the hand is palm up, it is supination. If you imagine you're holding a bowl of soup, which rhymes with supination, okay, the palm would be face up. Pronation would be when the palm is face down. Oh, your book does use inversion and eversion for the ankle. I apologize. Protraction and retraction. Protraction is to project forward. Retraction is to pull back. Okay, elevation, depression, self-explanatory. So protraction and retraction, if you ever go into a rehabilitation office as a nurse, retraction, you would see when people are doing retraction exercises, bringing the head back over the shoulders, okay, trying to straighten out that posture. So protraction is to protrude forward, retraction is to move back. Types of synovial joints. Okay, here we go. Gonna get into some good bread and butter stuff here. There's different types of synovial joints that I'd like to talk to you about that are very important to us, especially because we tend to injure them more often. Don't forget, synovial joints are movable. Okay, synovial joints are movable, so they tend to be injured more easily. Okay. Plane joints, you could see on this picture, the picture at the top with the arrows all pointing out, tend to slide on a flat surface in multiple directions, okay? Hinge joint would be like the elbow joint, excuse me, where you could see the lower right hand picture, and if, once again, you can't see this, pause the tape and get your book out, straighten the book, okay? Hinge joint would be just like the hinge of a door, where you'll have a nice concave surface with a convex one sitting into it, and you'll have one plane of motion. Okay, a plane joint would have multiple planes of motion. Synovial joints, once again, a pivot joint would pivot around a round structure. The upper right-hand corner, you can see there's a ligament around the head of the radius. Okay, and the head of the radius pivots right around the ulna. That's why that happens. Condyloid joint, you could see almost looks like a cup with a rounded portion that sits into it, like the metacarpophalangeal joint on the lower right-hand corner. Saddle joint is going to be just like a saddle, okay, with the opposite shape fitting right into it. Ball and socket joint will be what we have in our shoulders and our hips, okay? And those are going to be important ones to specifically go over. Okay. Knee joint, I know this is an absolutely crazy picture, so once again, get your picture out from the book. I'm going to zoom back out so I could go over these different structures for you. Okay. So with the knee joint, we have multiple structures that are very important for us to know. I've tried to draw arrows from the descriptions to the actual parts of the picture. I know it's a little bit confusing. We are going to totally go over all the structures in lab because there are so many structures. And I know this looks crazy with all these lines trying to point in different directions for you. Let me go through these in order and I'll point them out on the screen. Okay, so knee joint is going to be between the femur and the tibia. Okay, the femur are going to have condyles or two projections that are going to be